It's my pleasure to have on this discussion, in addition to our larger audience, two fantastic leaders in patient-centered hydrocephalus care. And I think that for clinicians, as well as for data scientists and software engineers and AI developers, it's important to understand the patient and family perspective, as well as the sort of overall outlook on what is going on across the various diseases that we take care of. And I can't think of better folks in the hydrocephalus space to speak about this than Amanda and Susan. So to do the brief bios that you can see up here, I'll note that they're both dear friends and really fantastic leaders in this space. Amanda, of course, is the COO of the Hydrocephalus Association, which is, I believe, the most important, and I think we could say things like the largest research funder, the most influential organization in hydrocephalus, particularly with its focus on both patient communication strategies, even using novel technology like apps, and its ability to bring together clinicians, scientists, and patients to improve our care for hydrocephalus, both in kids and adults. And so in that role, Amanda is really influential in driving that agenda forward, in addition to the personal connections, of course, to the disease. From an AI standpoint, of course, she serves in the direct-to-consumer work stream in the Coalition for Health AI, and has spent a fair amount of her own time improving her AI skills quite formidably. So Amanda, it's a real pleasure to have you here.
It's an honor. Thank you, Dan.
And Susan is also a health leader in many different respects. For this specific conversation, it's most notable to say that in addition to being a board member and former director of the Hydrocephalus Association, she has vast professional experience with both leading and building public understanding around complicated health issues, and even in developing infrastructure herself. So it's a real pleasure to have both of these fantastic panelists here with us today to share more about the patient-centered aspects of hydrocephalus care. So I think for an opening question for the panelists, I think the simplest opening question is around what do you think that scientists, that AI developers, that software developers should know about hydrocephalus that you think is unknown or misunderstood as patients, parents, advocates, and so on?
It's a great question. It's a huge question though, Dan, because there are so many different parts that little roads we could go down within that. Yeah, I think first I just want to level set really quickly and let Susan and I share a little bit about our personal journey so that it's in context for the individuals who are on the call who might have questions for us. I have a 25-year-old daughter who has hydrocephalus. She was born 3 months prematurely. I was 26 weeks pregnant when I ruptured. I went into labor at 28 weeks. Actually, we chose to deliver her at 28 weeks. Her heart rate was falling significantly. And then she was in the NICU and she developed a brain bleed shortly after birth. And they diagnosed hydrocephalus from an ultrasound in the neonatal intensive care unit. We were in the NICU for 96 days. She had 7 brain surgeries in the first 7 months of her life. She has had 17 brain surgeries overall, and we consider ourselves lucky in the shunt space and in the post-hemorrhagic hydrocephalus space to only be at 17 surgeries. She is finishing a 4-year degree at McDaniel College in Westminster, Maryland. I'm really proud of her living independently. But there's still questions about what the future will hold for us. So, that is scary. And so that is my journey. And the reason I want to level set and let Susan just preface it with her journey is then I'll go back to your question and Susan will jump in with me about what people don't really know about the condition, and I think what we still don't understand. So, Susan.
Thank you, Amanda. I think probably similarly to Amanda, kind of walking you back to how hydrocephalus became such a gigantic part of our life, is to tell a little bit about the story of my now almost 15-year-old daughter. So I have 3 kids. And back when Erica, my daughter, was 2, we were leading what pretty normal lives. My husband and I, DC working crazy people. At the time my kids were 10, 7, and 2. And just couldn't imagine life getting any busier. We ran from one event to the next. And I got a call from daycare that my daughter was not acting like herself. Something was, and everything up until then had been pretty darn normal. And I went to pick her up thinking, another childhood virus, and let her sleep overnight. In the morning, she still wasn't doing great. My husband stayed home with her and then called me and said she's really out of it. So I came home and we took her to urgent care thinking she was dehydrated due to a stomach bug. And they took her vitals and called 911 and brought in a crash cart. And by the time we got to the children's emergency room, she was completely unresponsive. And they started asking us all these crazy questions, like I never thought I'd ever be asked. Like, did she ingest poison? What kind of pills are laying around her house? They brought her into the CT scan, came out and said that there was so much fluid in her head that her brainstem was getting crushed. And we immediately needed to remove the fluid, and she had a disease called hydrocephalus. And I'm in the healthcare space and hadn't heard of hydrocephalus, and is being told that it's about, like, my kid is about to die from it. So needless to say, of course, they brought her in to immediately start pulling fluid off of her brain, and then started talking to us about ETVs versus shunts. And as you can imagine, my head was spinning. And we heard about the pros and cons of both, and ultimately decided at that moment in time that an ETV, an endoscopic third ventriculostomy, sorry if I'm assuming folks know what that is. If that is an unfair assumption, we can definitely get into that. But we ultimately decided, okay, let's try for an ETV. It seems like my kid's etiology would potentially do well with it, but so many unknowns. Like, is this a better solution than a shunt? But we were just eager to see our child again. At this point, was gone. And so we did the procedure, and then she fell into a coma for days. And we were told, like, we think she's gonna wake up, but we hope you're gonna get the same kid back, but we'll see. And those were just the most terrifying days, as you can imagine. She did wake up, and she sang Happy Birthday, which at that moment in time was her favorite song to sing. And so we were super excited about that, and then realized she couldn't move her leg or one side of her baby. She had multiple strokes in the process. And so we were then also told, of course, that hydrocephalus is incurable, and that at any time, without any, perhaps without almost any symptoms, that we could be back where we started, and that her life was in jeopardy. So that, holy crap, like, never imagining that I would have a child who would need brain surgery, much less, like, at any moment she could need more of them. Are you kidding me? And now I have a paralyzed kid who, oh my goodness gracious. So the rest of our lives, of course, went on complete hold, like immediate stop, to my professional life, my husband's professional life, our other kids. And we moved into a hospital for sick kids in DC, where we planned we were going to stay until our daughter walked out. She was walking a few days before, and at the moment she was paralyzed, but we were going to be walking out. And after 6 weeks at the hospital for sick kids, we couldn't take it anymore. My husband and I were switching on and off every day, and sleeping there every night with her, of course. And we were the only parents to sleep there. All the other kids were by themselves. We left with our daughter in a wheelchair. over the course of time, she learned to walk again. She still, and thankfully I didn't know this back then, but she still is in physical therapy. And so that's just, she's doing quite well, you know, certainly all things considered. She has some learning challenges. She has mild cerebral palsy. She is walking again, but pretty wobbly. Like we often joke, you know, how much whiskey did you have before you got up today? And of course, as you would expect, a lot of anxiety around all of this. Not to mention the fact that her ETD failed about a year after the initial surgery, and so we had to go back in and open it up again. The process to get there to open it up again was far less simple than I would ever wish on anybody. You know, as a little kid, and what you're told is you have to watch for symptoms to know if your kid's in failure. And the symptoms are, for anybody who has kids, fever. No, sorry, not fever. Fever is a good thing. Sorry, we like fever because they may mean that there's a regular body. Vomiting, head pain, out of sorts. Like how many kids vomiting, head pain, out of sorts? Like that's like a weekly occurrence, right? When you have little kids. But in our case, what that meant was typically a trip to the emergency room where you would do imaging and you would have a conversation with the neurosurgeon and or the radiologist or whoever, saying, what do you think? Like, here's what the images say. In our case, like the flow seems good, but maybe it's not good enough. Maybe we need to open it up a little bit more, but maybe not. So we had a lot of trips to the emergency room for a long time. Anyway, the process of being a parent, as you can imagine, and under these circumstances, is pretty darn stressful on the whole family. We are on the other side. Amanda became one of the most important people in my life because I so desperately needed support. Her journey predates mine by about a decade, so she has been just fundamental to our whole family's experience over the past 10 years. So that's a little bit of background on the patient experience of hydrocephalus, and I'll go back to Amanda.
Well, I think you teed up some of the responses to Dan's question, like from a data science or from a data scientist or development tech development perspective. You know, we live in a black box. Like our children's heads are a big black box. We can't see what's going on inside of our kids' heads. So, you know, a fever might not have been a big deal to Susan. A fever is a big deal in the shunt world, or out of sorts, lethargy, headache, you know, just wanting to put their heads down, fall asleep. All of these can be symptoms that something is wrong inside of their heads that need to be addressed immediately, or you could be talking about, you know, potentially long-term permanent brain damage if there is an intervention in time. And so one opportunity, of course, in this space is understanding what is going on in our children's heads or adults who are living with hydrocephalus and being able to monitor that. But Susan, you know, you also talked about something else, like, and that is the signs and symptoms of a shunt failure. And Dan, I hope you chuckle with this, and I'd love your perspective on it. But I will tell you, having supported thousands upon thousands of people over the course of my professional career at the Hydrocephalus Association, and also just talking with adults and individuals with normal pressure hydrocephalus, who is our senior community, as well as kids, everybody's hydrocephalus is unique, and it's also really complicated, and nobody does it the way their kid does it or the way they do it. And I say that a little tongue in cheek, but it is true. Like, we hear that all the time. My kid doesn't fail the way everybody else fails. Or I don't, you know, my symptoms are completely different. My hydrocephalus is so complex, it's completely different from anybody else's. And in a way, that's really true, right? That's the hard thing about hydrocephalus, is that while there is some commonality across the patient population, there is also variability. 2 children can be born from post-hemorrhagic hydrocephalus, grade 3 IVH, same area of the brain. They could be 2 completely different kids on this journey. One could have 2 brain surgeries for the first 25 years of their lives. maybe even 45 years. And the other one can be in and out of the hospital and dealing with a lot of other comorbidities, seizures, cerebral palsy, learning disabilities, major anxiety then sets in. So there's that. So where do you key in on? You can't put all of these kids in a box so that the AI can run over it, right? It has to be able to really understand that variability and nuance. And then I also think, Dan, Jack Walker, the grandfather of pediatric neurosurgery, and so beloved in the community, always said, you got to trust the mom. The mom's going to know if the kid's in shunt failure or an ETV failure. Where does technology play in that piece of the pie? And there's so many other places we could go into, right? And you're going to ask these questions: surgery, imaging, like all the other things that we deal with. But those are just a couple of things that Susan brought up that I thought I would tee off to see how you want to engage in the conversation around development, data, tech.
Yeah. So, I mean, so many questions, I think, just for the audience, and, just to underscore, hopefully this is being recorded and disseminated. There's fairly good scientific evidence about, the fact that you should really trust hydrocephalus parents who've seen a shunt malfunction before. And they're really important, actually, diagnostic tools, the parents themselves. So this is really important. And I think that sometimes it's difficult because we see so many different diseases as surgeons and as physicians, to know what the role is of parents in the diagnostic process, right? Like oftentimes we think about parents as part of the therapeutic decision making, right? And say, oh, what are your values? Do you want surgery A or surgery B, or do you want to go to hospital A or hospital B? But I think there's really a lot of value in any specialty, but especially in hydrocephalus, and understanding what are the roles of parental concerns, and how do you work with a parent in this case to arrive at a diagnosis together, integrating their opinion, frankly, into all of the other tests that you need to do, and as really a key piece of information in this puzzle, especially if they've seen their child have a shunt malfunction before. That is really powerful. And the nearer you are to the kid, we see kids from all over the world who come to get care in DC for a variety of different reasons, and sometimes we need to pick up in the middle of things. So I think,
Dan, just to jump in and represent the adults for 1 second, I hear from adults all the time that people don't believe them in the ER when they're coming in with shunt failure. They know their bodies so well, and they are dismissed. And I think that is a really wonderful opportunity, right? But it is really heartbreaking, that they go home, then they have to come back, and just the amount of suffering that they have to, get through before somebody will listen to them. So not just the parents, right? But I think when these kids transition to adulthood and have been living in their bodies and know what a shunt failure feels like, to not be listened to is really challenging.
Yeah. Yeah. Thank you, Lauren, for the comment. I think it's I think the transition is particularly challenging, and I'm curious if you guys can share a little bit about both of your experiences. You now have either really big kids or really small adults, or probably a little bit of both in different ways. How does that work? How does that happen? What is a pediatric hospital and an adult hospital in the world of hydrocephalus? I know this is something we talk about all the time, the three of us.
Yeah. Well, Susan's still solidly in peds, which is wonderful. I miss peds. When Gabby was going through her early life, and we were just in and out of the hospital, and especially those 96 days in the NICU, but then the subsequent surgeries, I remember thinking, this is so hard. And then my kid turned 17 and I was like, this is a lot harder. Transition is crushing because it's not just the medical transition. For anybody who's got kids that have, learning disabilities, who might struggle with executive function and memory, and getting into a college that might have the appropriate supports for them, the insurance issue. My daughter's 25. I literally don't know what we're going to do in 26. I'm starting to talk to navigators now to help me figure out what type of insurance are we going to be on, Medicaid, you know, what are we going to do? You know, she's in college. So, you know, there's all those questions. So there's the insurance questions. There's also is my child going to be able to support themselves? So now I'm looking at my legal documents. I'm looking at my long-term financial planning, you know, and it's not just transitioning to, you know, it's not just the long-term, like what happens to me within the next, you know, 5 years. It's also, you know, if I pass away, who is going to take care of her if she's not working? What if I'm gone and she's 35 or 40, has a surgery that doesn't go well, and now she's disabled? Who's going to help her navigate that? So there's so many, for a parent, there's so much stress around the transition phase that extends beyond the hospital. But the hospital in and of itself is jarring because you know, there isn't the Disney playing on the television sets and people being really welcoming. And, you know, it's like, are you checking in for surgery? Yeah, I am. Yeah, we're checking in for brain surgery. You know, a little smile, you know, anything, something a little nice. You know, it's a much more sterile environment. You make your relationships with your doctors. You don't see them as often. Some adult doctors don't see hydrocephalus, neurosurgeons don't see hydrocephalus patients at all. They might see a PA or an NP, which is wonderful and fine, but it's a different world. Or they might just be told to come into the ED when something's going on, and the doctor will see them then. So you're not establishing a relationship. So there's a lot of nuances in that transition time with the medical, as well as the everything outside of medical, trying to find jobs and insurance and long-term financial planning as well.
Fantastic. For Susan, I want to segue a little bit into, you know, we think a lot about ETVs and ETV CPC, and, you know, I want to recognize, you know, Derek is here in the audience with NeuroKids, and they're a phenomenal partner for us, really an innovative organization that's helping make the procedure that, you know, Susan's daughter had much more available around the world, because not everyone can get a shunt. And, you know, as Amanda's clearly explained, imagining what shunt care looks like in a setting where neurosurgeons are not available, and those, you know, numerous surgeries maybe can't be so easily performed for a variety of reasons for most people around the world. You know, when you think about when your surgeon was talking to you about ETV, what did they, you know, and now knowing more, what do you think about what matters to you about an ETV type procedure where the surgeon uses a camera to make a new fluid pathway rather than placing in a drainage tube?
So it's definitely was a much more appealing option, certainly, than a shunt. Having been so involved in the Hydrocephalus Association for over a decade now, we have people in our community who have had over 100 revisions with their shunt. It's just stunning when we think some people a lot of people think have bodies that do not accept shunts, or certainly don't accept them for the long term, and living a life like that sounds terrifying to me. So an ETV sounded like back when it was originally presented to us, and has been, it seems like it puts us in, we've been, and I almost hate to say it because I'm so superstitious, it puts us in a lucky category in terms of not having the number of surgeries that I find so many other families of shunts seem to have. I wish I had a crystal ball to know that in our situation, an ETV was a better option for our child. You know, of course, we'll never know. Maybe outcomes would have been better had we shunted. And the thing that we certainly see when we do the imaging is that my daughter still has giant ventricles. You know, that her head looks super, super fluid filled, which maybe is fine. I mean, you talk with her. She's seeing it. I wish she were here with us today. She can talk in the most articulate way. She's just brilliant. And so maybe it's perfectly fine. Maybe it's great. And it's been wonderful to be surgery free for over 10 years. That is, like I again, because I'm so superstitious, I hate to say this, but for so many years, every time I would be at work and my phone would ring, I would do an automatic calculation of how far am I from her and how many minutes will it take me to get to her and get to the ER. Like that was always, I mean, every single time my phone rings. And what an anxiety-riddled way to live. And at the moment, I'm not doing that. And haven't been for a while, and that to me it's the blessing of the ETV.
Yeah, that makes a lot of sense. So I want to pick up on something you said about your, if your surgeon had a crystal ball. I think that somehow one of the things, that we think about is, can we create a technology that functions a little bit like that crystal ball? But I'm curious, as parents for both of you, how would you feel if your surgeon essentially said, well, I'm going to consult a crystal ball for some portion of your care, or I'm going to have a crystal ball with me in the operating room watching me operate, and then it's going to tell me whether I've done a good job or whether I should stop or go farther or make the ETVostomy bigger so it flows better, right? What would, imagine,
I would pay all the dollars in my bank account for that crystal ball. I want every possible advancement imaginable when it comes to the care that my daughter is getting. I feel like we are so many centuries behind, if possible, in treating this condition. I mean, one of the, when we've had challenges in the past and because we don't know what her intracranial pressure might actually be like, they still do this crazy procedure where they, drill into the head and insert a bolt, and kids have to lay in a hospital bed while their ICP, their intracranial pressure, is being measured by this equipment that looks like it's straight out of like a Frankenstein movie, to try to understand if their pressure is too high. Of course, there's no like control person next to that child with the same bolt in their head to assess like what is the right pressure somebody is. So yes, please bring in all the crystal balls. Please, 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 please. Bless you all who are coming up with these incredible advancements.
I think I would agree. I think I would also just put on the table that there's the operative outcomes and the prognosis in terms of the physical structure of the brain and how well the surgery goes. But the other part of the outcome that's important for parents and that we want a crystal ball in is also what are the neurodevelopmental and neurocognitive outcomes. And this is what I alluded to earlier, where you can have two kids who have the same etiology and their roads are just so different. So, the domino effect of, and who knows where it comes from, right? Is it the initial injury? Is it the number of interventions or how those interventions are done? But, the learning disabilities, the seizures, the anxiety and other severe mental health, the chronic pain issues that this community faces, that's all part of prognosis for me as well. The crystal ball, I would love that piece of the crystal ball to be, able to show me that as well. Of course, I want the surgery to go as absolutely best as possible. But the other part of being a parent is I got to plan and support my child to be the best version of themselves. And I need to understand where those challenges are going to be so I can do that. And I do think that there is opportunity in the space with that. Like how, Dan, I know you're doing a lot around education and upskilling, right? With the SDSC. And I think it's so amazing. And can this technology find ways to do the surgery more effectively in a way that is maybe more precision, less, fallout damage to other parts of the brain? I mean, not that typically happens, but, just like, like I think about like the microblade, like, can it be a smaller device that's going in? Can it be much more precise? It's not going to go off track at all. Would that help with the long-term outcomes, right? the less we're really, penetrating the brain. And then I look at, alternative treatments, like what's happening with the e-shunt, with Ceravasc, that we're shunting now through the vascular system, as opposed to having to drill a hole into the brain and penetrate the brain to get into the ventricular space. There's opportunities there. So for me, prognosis, I would love it if that crystal ball could also tell me a little bit about what my journey is going to be like outside of the medical room. Is my kid going to have friends? Because they're socially going to get the jokes that they're missing right now, because they're just flying right over their head. They're going to be able to write a paper and see all the beautiful innuendos in text and the secondary messaging in text. Or are they just going to interpret it literally, and we're just going to write the paper literally, and they've missed this beautiful part of the novel that they're reading? So.
Yeah, I think I saw a hand raised somewhere in the audience. So if there is someone who's interested to jump in, I'm happy to give a minute for that. Yeah, Laura M, I think you may be on mute. Or at least I'm not receiving the audio.
Yeah. Can I ask a question while Laura's figuring out her audio?
Mm-hmm.
One of the things that worries me about the surgical space with this incredible speed of development in technological development, AI application, is potentially, particularly with these younger generations that might be being trained on AI, with AI tools, the over-reliance on the tools and the AI in the surgical suite to make decisions. That worries me a little. And I'm curious what conversations you have had around that space, Dan, and how that's being addressed.
Yeah, I think you're pointing out something that's a really important challenge whenever we're developing any decision support or any sort of potentially assistive technology. And we've never had tools like this before. They're not necessarily going to be fully integrated into the training process. And I think that's why at SDSC, we really think about what are the tools that we can create that can be integrated into the process that we already understand, that can help improve human performance, and not simply be a replacement for, I just gave this talk earlier this morning in the Seattle Science Foundation, starting exactly with this point of, I don't have a vision where human decision making is going to be replaced by AI decision making, but there are a lot of things about AI understanding what we do in various operational parts of medical care that AI can actually point out things that we might want to attend to, might want to pay attention to, that we're currently neglecting or currently misunderstanding. And I think that's probably the best role for the technology. I think there are other areas where that is a really big concern. And the techno-optimist in me wants to start talking about, horses and cars and, do you really miss your horse, stick shift. I know how to drive stick shift, right? But how many people under the age of 30 have ever driven a stick and will ever? That being said, I think that there's a lot of stuff we can do before we get into that problem to make people better, safer drivers. Like backup cameras are phenomenal. I still look at my mirrors, but I'm really happy to have that backup camera that beeps when I get too close to something. And it makes me a better parallel parker, as much as I hate to admit, right? Because parking spaces are unusual, and sometimes I'm trying to fit into a space that's too small, and all of these various things. Similarly, I think when we develop technologies for improving medical care processes, we can really focus on making the technologies that enhance the overall performance of the human and the technology together. And that's probably where we should be spending most of our time focused.
Yeah, I worry a little bit about, again, because the variability is so high in how people fail, like what you see. I remember my daughter's last shunt failure. It was actually a 6-month period of watching her memory just kind of decrease, and then she failed a test in a subject. She didn't fail test, period, and certainly not in this subject. And that's what led us to doing a flow study, and realizing that she had actually developed to a major cyst in her abdominal cavity where both of her shunts were draining into. And so her shunts were not draining well. But it wasn't headache. It wasn't fever. It wasn't any of the textbook symptoms that I worry with the application of AI. If people become reliant on it, it could even hinder proper, acknowledgement of a shunt failure, just because it's not fitting in the box of what the differential diagnosis would be, right? Like they're running it down it, So I don't know what your thoughts are on that, because I think we think about the surgery suite, but there's also application of these tools in other moments in time in our patient journey.
Yeah, I want to try to get Laura, if you've gotten your audio going.
Yeah, I did.
Awesome.
I think, yeah, I did, right? I'm sorry, I'm like a half an hour late. I was trying to find the email to go onto it, and I realized there was no email. I had a hard time getting here. So here I am, half hour late, but I haven't had surgery in it's going on 38 years in November. And I feel like my shunt is heavily calcified, and I feel like it's broken up and down my neck area. But I fell on my head. I tripped on a uneven sidewalk and I got a CAT scan, and they said, "Oh, your shunt looks great," and that's going to look great with calcification. I have indigestion that won't go away. I'm on 4 different meds, and if I skip one of those 4 meds, 2 of them cause dementia, by the way. So if I don't remember you by next week, you know why, because of my indigestion meds. I try to tell them about Cushing's ulcer, which is something I had never heard of. I've heard of Cushing's disease, but not Cushing's ulcer, and I'm concerned that that's why I have indigestion. It's how I came into the world with it. So it's like it's how my hydrocephalus presented when I was 6 weeks old. No one would listen to my mom. They said, "Oh, she's colicky." And then I had sunset eyes and I'm rushed into surgery. And I feel like it's kind of like full circle where I'm having those symptoms again. That's how I feel. It may be wrong. It may be indigestion. I'm not eating hot foods anymore, and I don't eat fried foods. I'm a clean eater. I'm a really good eater. So, and trying to tell doctors this, I know the writing on the wall is that they're afraid to do surgery on me because it's been so long. I know no one's more scared of it than me, but I see my sister's a doctor, and my mom and my stepdad, my mom's going to be 79. She's going to be 80 in May. And I see how they're treated in the office. I want to be treated that same way. They're treated so different. They're rushed right into whatever they ask for. And I'm rushed into nothing. I couldn't even get a doctor till recently this year. And I feel, I was told in Boston that my recall skills were the reason they sent my records to the wrong, 2 out of 3 doctors, they sent it to the wrong person. Wrong address, wrong person. I had written them down, including the suite number. I worked at a law firm, and I'm sick of being treated like that. And I worked so hard to get a doctor, and I'm probably more scared than anybody that I might be in shunt failure after all these years. And I'm kind of complacent, oh, it's never going to happen. And I've had doctors tell me you probably don't even need a shunt anymore, but I've slit ventricles, which says to me I do need a shunt.
I love that Laura just so beautifully explained what I was trying to explain about what the adult population is facing. The things that you've brought up, Laura, are so many. There's 5 different places where, I think technology and or the use of AI or even just some good old fashioned training in patient care could be used in your space. Thank you for sharing all of that.
Yeah, thank you, Laura.
It's
Kate,
good. So anyway, thank you. All right, now let me try to figure this out.
all right. Kate, thank you for joining us.
Hi, everybody. So I both work at SDSC, but I also am a parent of a child with hydrocephalus. So I have met Amanda and Susan before, and it was nice to meet you, Laura. And it was, Laura, your story, even though my child is 17, really resonates. I wanted to talk a little bit and maybe move us to sort of your questions, Amanda, about sort of where AI could fit, and then kind of ground it a bit in the context of SDSC, because I think you're really talking about the preoperative, which is where my conversation on the use of AI really started. The operative, which is I think where SDSC really focuses, as well as some post-op. So in the preoperative, a lot of the, let's say, so I came out of the technology sector, so a lot of it's really around what are the specific use cases. And one of the main use cases was precisely because of all of those comorbidities. And like we see Sam Browd, Dr. Browd, like once a year, 30 minutes. We do a shunt, we do the shunt series, we do everything. We walk in, here's our imaging, everything looks fine. Laura, my kid, has many, many challenges, and we all kind of think, you know, yeah, we get that the shunt looks fine. And we're all kind of trying to figure out, do you do experimental surgery just to figure out, is there something else going on? Because there's a lot of other stuff going on. A lot of it, to me, is the use of AI to actually gather and assess and analyze and more easily provide to the surgeon as you're going into him, what else is going on? Because we spend 25 minutes as the parents being AI.
Yeah.
So if we could actually collect all of that from his 5 different doctors who are across every other part of the system, many of them not even within the same hospital, and kind of bring that in and have that in his medical record before we ever walked in the room, how much better would that half-an-hour appointment actually be in helping us debate and discuss choices around, do we do an experimental surgery or not? Because we're spending 25 minutes just catching him up on history. And that's actually really hard for them, like a Dan, to then figure out what to go operate on, or should we do an experimental? Because we are daily, as the mom, seeing like, he has no executive functioning. He really can't, like, you know, remember to brush his teeth at 17. He's failing tests that he shouldn't be failing because he, or doesn't hand in homework because he just completely forgets. Anxiety, depression, cannot stay awake and has to nap as a 17-year-old for an hour and a half every day. Like, this is not stuff that's actually that normal. And but it's nothing so severe that it's going to trigger anybody else. He shows up like a basically normal kid, except he's not, and he doesn't get the jokes, and he doesn't get all of that. So I think your ability, I think there's a massive case for the use of AI to really help translate for the parents the things that often come out as emotion in a room. And for a doc who is very pressured for time, to have a much clearer record and understanding that you have actually, yes, an AI assistant can help you capture that record and then provide it in such a way that you can then go edit it and make sure that it really reflects your experience. But it's a very helpful tool to guide the medical process versus replacing the medical process. At least that's the way I think about it. I think in the operative side, it's really about, as Dan was talking about, really like, how do you increase the availability of the types of surgical procedures that people can do and get better at them, particularly when they're only seeing them a couple of times a year. Like my kid, Susan, is only 2 years older than yours. We weren't even offered ETV CPC. It might have been a much better option for him, but we don't know, right? And I'm not sure at that point in time, it was actually being practiced that heavily within, because it was, I remember talking to Sam about it like a year later, and he was like, oh, this is kind of newish thing. Like, hey, we're experimenting with this, but we already had to shunt in. We're not going to go pull the shunt out, right? So I think there's both, I think there's that side of it, which is on that. Then I think there's the tracking and being able to reply back, again, an AI assist to do it. But your ability to improve the surgical procedure, improve the quality of the residents who are doing, overseen by somebody else. And quite frankly, for me, who had come out of global health, offering that in other locations. I mean, we looked at moving many times for my work to Africa or Southeast Asia. We never could, because there wasn't the machinery, there weren't the doctors, there weren't shunts. And if it was going to fail, we had very little time. And, you know, we can barely get it diagnosed well in the US, much less am I going to drag him then to Africa and then say, okay, you're on your own and you're going to try and figure it out. We're going to get on a plane and fly you to South Africa so that you can go get a shunt surgery. Like, it just doesn't happen. And so, you know, for these kids, we're limiting their lives, or we're affecting them forever, in, as Laura is, and then they aren't really believed. But if you had a much better record, and that could track you through, and then it could all be pulled together. I think it would be very helpful in addition to just improving the surgical availability and quality of care. The last thing I'd like to say is I think it also has the power, and this is particularly coming out of the surgical side, to drive new innovation and research. Like, we really, as we know, haven't had much innovation in the shunt space in a very, very long time. And we have tough, as I'm trying to raise money for my Seattle walk, like, we have very tough, funding constraints, and we always have, and it's only getting worse.
Yeah.
And so how do we actually help the researchers and clinicians, and also maybe get some of the manufacturers to actually consider innovation in a space that to them is just not that cost effective, or sorry, that profitable. Sorry.
I want to finish one thing that you said, Kate, at the very beginning, around having these more comprehensive records that AI could really help generate for doctors, and say that there needs to be a patient component to that, which is where HydroAssist and other things are able to fit into that space, which is patient collected data that they can send to the doctor that can be incorporated in any of those AI summaries, right? So HydroAssist, a lot of users use HydroAssist to track their symptoms all the time. And it's not just symptoms like a headache. It could also be memory decline. People are keeping notes in there, and they're able to send that through text or email to their doctors. It's also being able to accept patient-driven tool like reporting into the record, so that is part of the pre-operative workup that they're doing. And Dan, I don't know how you feel about that, but I love everything else you said, Kate, but that is the one thing that I was like, patients need to be able to provide input into that part of the equation.
Yeah, and I think one of the things that's so exciting, and I'd love for you guys to share a little bit about the HydroAssist journey of, where it came from, just for everyone who may not know about it. But I'll say this, when there are other digital health tools that exist that we don't provide us with the kind of information about the things that parents care about, that aren't in the medical record, right? To your point about the finer points of neurologic function or even general functional status, are assessed very coarsely. And what is required before we could plan a surgery to rationally improve one of those things is this reservoir of information. And in the places where that's available, we can look and see, hey, this is the part of the surgical process that drives this outcome or that outcome. Because right now in hydrocephalus, we pretty much look at, did you live? And did you need another surgery within a time period? And there are some notable exceptions. There's some things around infant development that have been done that are also very coarse. But those are few and far between. And I think that these kinds of organizations like HA and others can really play a beneficial role in their disease focuses by sort of shining a spotlight on and collecting the data for the kinds of tools they want to see exist in the world.
Absolutely. HydroAssist, came about from a pediatric neurosurgeon out of Cincinnati Children's, Dr. Jesse Scotch, who was actually a resident at the time in Arizona, and Dr. Abe Mogakar, who is a neurologist out of Johns Hopkins, who is the co-chair with Dr. Mark Luciano of the CSF Disorder Center up at Hopkins. They independently were developing apps to help their patients track just their treatment. It was kind of like taking the good old-fashioned shunt card and digitizing it, right? So patients, but with a little bit more gusto behind it, because you'd be able to input anytime anybody touched your shunt, whether it was a surgical revision, a full swap out, a programmatic change to your shunt valve. And it was basically to be able to track all that initially and be able to send that to a doctor. In addition, the second phase of the HydroAssist was to integrate imaging so that families could be traveling and at least have a set of images that could be texted or emailed to a doctor in the location that they were at. So they had something to compare imaging they were getting to, particularly if they couldn't get imaging in time from the treating institution, especially if they were abroad at the time. And that has the HydroAssist was all developed from donations from our community, and a couple a couple larger gifts that we were given specifically for the app. And that, to Kate's point, that is part of the struggle, is that the app can only develop, as we get funds to be able to continue to improve it, which is why it doesn't improve as fast as we would like it. But it then became a tool. There are 40 people who sit on an advisory group to the app, and they help define what the next steps are for the app, the roadmap. And they said we need to integrate a way to list our medications, some basic information about who we are and our journey, how we developed hydrocephalus, and we need to be able to track symptoms. So all of that has been brought into the app, as well as the ability to allow different people to manage different parts of the app for you, like a spouse or a parent, for example. The next parts of the app, though, are the most exciting part. And, Dan, this is all about that data collection space. From the app, obviously, we're sitting on a lot of incredible data that can provide really amazing insight into the patients. But we also have a patient registry that the Hydrocephalus Association developed, which tracks an incredible amount of additional information, from the neurocognitive challenges and diagnoses to medical insurance questions to are people getting IEPs and 504s in schools, or are they getting supports in the workforce? Are they maintaining jobs? Are they working full-time, part-time? And now we're looking at how can we take those two data sets and bring them together to really paint an incredibly detailed picture of this patient population. And so those are the directions that we're looking at going in, and how then can we open that up to our research scientists and industry partners to provide them the insights they need to take the next step in the development of new innovations around diagnosis, treatment, and care. So that's a little bit of the background on the app. But Kate, as you really pointed out, and I'm fighting for the DC. Susan and I are raising money for the DC walk, so we're with you on the other side of the country. We only can develop the app as quickly as the money that we get to bring into the association to work on the app, and it's a hard time right now. It's a really challenging time for fundraising and for nonprofits.
Fantastic. So we've covered a lot of ground. We've talked about, everything from the first diagnosis to the tumultuous care for adults. And I'm curious for Susan and for Amanda, maybe start with Susan first, what is the I'll start with the question I first asked. If you could snap your fingers and have, one misconception known by scientists, technologists, developers that want to help patients like this, what do you think you would share with them that would be difficult for them to otherwise understand?
So the thing that was said to us when Erica was in the hospital when she was little, by many of the physicians who came and sat with us, was, "Hey mom, hey dad, your kid has a plumbing problem, and we're your Roto-Rooter people. Like, we can go in and solve your plumbing problem." And I have to say, I appreciated the making light of what was really challenging to digest at that time. But obviously that is such a minimization of the massive impact hydrocephalus has had on all parts of our life. So there's just, as we've discussed, so much to this diagnosis for some of the folks who get it.
Thank you.
Yeah, I think the misconception would be that, and it's kind of as along the lines of what Susan just said, that the treatment is okay because nobody's dying. First of all, people are still dying from hydrocephalus. I just made our Ambassador Avenue Memorial Garden, and we just had a little 2-year-old she would have turned 2 in a month, and she's not with us anymore. So there's a misconception, but that this is okay. Oh, well, it's working. Shunting's working. We're draining the fluid. ETV's working. It's okay. No, it's not okay. The life that we are living is 100% not okay. This is not good enough. It is exhausting. It is exhausting on an entire family. Families don't make it through this. And it is hard on the siblings. It is incredibly mentally and emotionally challenging for the individual living a life where they don't know if a headache is going to mean they're going in for brain surgery, that they're struggling to stay attentive in class and muster through pain or just learning disabilities. And for parents, you know, our lives are completely shifted and changed. Not only do we also live with PTSD, which was proven by Dr. Brandon Rock out of the University of Alabama in a study that he did of parents and patients living with hydrocephalus. It was the patients were okay. They certainly live with stress, but parents were actually found to be living with PTSD. That's not okay. That is not okay. So the current treatment modality, whether it be an ETV or shunt, is not okay. That conception needs to go away. What we are living with is not okay, because it's not just about what happens in the surgery suite. Our lives are consumed by so much more from this condition, and it is exhausting. And I'm terrified to die, because who's going to take care of my kid?
Well, thank you guys for the frank and really incredible discussion. I want to see if there's any questions from any of the assembled engineers and scientists who may have something they want to ask these, you know, very forthright and really incredible panelists here today. Yeah, Jack, excellent. Go ahead.
Do you guys hear us okay, by the way? Because the Wi-Fi here is a little shaky. Just like a massive thank you for sharing everything. And the question I had is, I guess, kind of peripheral to AI actually, like, and I wondered how, like, listening to your guys' story, how that there are kind of like tech solutions and then there are non-tech solutions to some of the issues you guys have been facing. And how there may be a way for AI to kind of like act as a conduit for the human network that seems like really important between different parents. It sounds like you guys all came together with the same struggles and a lot of the same issues and found each other. And I wondered how like hard that is currently, and whether you see the AI could act as a conduit for bringing all the different people involved in hydrocephalus, whether it's parents, patients, surgeons. If there is, like, I know you guys are working on an app right now, but like, is there a plan for like a kind of platform for everybody to join in, and or does that not exist right now?
Susan, do you want to talk or do you want me to talk?
I think you should talk about that.
Right now, Jack, I would say I have just a couple of thoughts on it. There's no replacement for human connection. For me to be able to be with Susan, for her and I to even put a hand on each other's arm or hug when things are really hard, or cry with each other and have it be real, that is really huge. So I hope, as Dan always positions it, that AI is a tool and not a replacement. And there is a fear for me in terms of emotional support, you know, that a lot of our kids feel very comfortable on technology because they struggle socially. So it is much easier for them to text a friend, or because they can control conversation when they're in groups. You know, for some of our kids who have some of the learning challenges and ADHD, a lot of conversation around them, they don't know where to attend. It can be really challenging. So they rely on tech. One fear I have about AI kind of being a platform, you know, or creating a platform for kids and interacting on it, is a false sense of intimacy with something that's not real. And that isn't going to push them right outside of a comfort zone. You know, to get my kid out of her room and off of her iPad can be challenging. She's 25, like, right? Like, I'm like, yeah. But she's like, I feel safe here, right? But the world isn't safe, and she has to live in the world. And that is a concern I have. But in terms of other places where AI can create forums and stuff, I think there's real excitement. Even on our own website, right? Like, we're going to bring in an AI chatbot because we have so much information and stories on our website that people can't access because it's so deep that, you know, there's a place where you are creating emotional support and educational support through the use of AI, being able to bring out the things that people are really searching for without having to do the clicking and trying to find it. And again, and I also think one of the things that the Hydrocephalus Association is hoping to do with data is creating a platform where we hold workshops throughout the year. We just had an engineering workshop, which brought engineering students. We're like, okay, let's think outside of the box, right? Like, great neurosurgeons, we've all been trying to tackle this. Let's bring engineers to the table now, and let's let you guys think about this. Solve for X, right? Like, and it's again, even everybody at that workshop said, you can't. This interaction in this room, our brains being physically in the same space, is such a game changer. That was a resounding, like, you know, statement that was made by the attendees. But that doesn't mean that you can't keep the conversation going in a space that is being driven with the use of AI too, to drop, you know, interesting questions, be pulling information, bringing it forward, things like that. So I don't know if I'm fully answering your question. And maybe I'm an old fart and I'm a little skeptical about AI. I like get nervous about, you know, movies like Her and stuff like that. Like, people are developing these really intimate relationships and trying to find answers. I think that there's always has to be a human component, particularly on the mental health space on the patient side.
Can I just jump and add one more thing on to what Amanda just said, is that maybe this goes back to the missed question of when you're getting a hydrocephalus diagnosis and you are learning about your surgical steps you're going to take. I think that is one of the steps that needs to be involved in your plan. As we've talked about, there's a big mental health, PTSD, there's a lot of baggage that goes with it. And I think at this point, most families, when they get a hydrocephalus diagnosis, they wind up in the hands of these amazing neurosurgeons, but the neurosurgeons alone can't necessarily deal with the full spectrum of issues that come up, and why every neurosurgeon doesn't immediately shunt families off to things like the Hydrocephalus Association, so that families can get support that I think most of them need, is a challenge that still exists.
Fantastic. Well, I want to thank everyone for their time and attention this morning. I know we have an internal follow-up for some of the SDSC folks to continue the conversation. I want to foremost thank Susan and Amanda, who've been phenomenal panelists, in our audience for great participation today. I think this has really shined a light, you know, something that I get to see in my clinical world often, but only through small slices, into, you know, what does a lifelong disease look like? And how big the problem is. And sometimes that can feel overwhelming. I think that together we can find the manageable pieces of this that we can each move in our own ways. And together, I think those can dramatically transform care. So thanks everyone for your time and participation today, and for another wonderful roundtable. Thank you.